Hi, everybody. So I'm a emerge physician in Edmonton, Alberta, Canada. I did my PhD in using ketamine as a primate model for schizophrenia. And my master's before that was looking at antipsychotic neuropharmacology. And then I ended up doing a 5-year residency program in emergency medicine. And so that's where I work clinically now is in the emergency department, where we use ketamine quite liberally for a number of different indications there. This work came about with one of my colleagues in Edmonton, Dr. Jennifer Swainson, is a psychiatrist and helped write the CANMAT guidelines. And she felt that maybe there might be some benefit to having emergency medicine's input on the guidelines with regards to management of hypertension during the administration of ketamine for treatment-resistant depression. So just a quick overview. I won't be talking about ketamine for treatment-resistant depression in this talk. I think most people here are probably pretty familiar with its indications and its administration. Rather, we'll talk more about how ketamine affects blood pressure in a physiological way, hypertension and the hypertensive emergency and defining those clearly. Then we'll talk a bit about evaluating the clinical relevance of ketamine and hypertension, and then lastly some recommendations that we talked about in the publication that came out a couple months ago in Frontiers, and where that comes from. So as far as ketamine and hypertension go, ketamine was established as a medication back in the 50s, and in the 1960s, using some dog studies, they determined that by blocking the sympathetic nervous system, they're able to block the effects of ketamine on the increased heart rate and increased blood pressure that it often induces. In the 1970s, they did further studies in these dogs that looked at serum catecholamine levels and that found that after ketamine administration, the levels of epinephrine and norepinephrine had increased quite significantly, and thus concluded that this is likely the pathway that leads to increased blood pressure and heart rate after ketamine administration. There's always been some concerns regarding ketamine and hypertension, and so from the emergency medicine literature, this actually was a big part of our training, where there's always been a concern that ketamine might increase the intracranial pressure. And now in patients with traumatic brain injuries, which is more relevant to the emergency department, the understanding was that because there's this potential risk that if we're ever needing to sedate or intubate a patient with a possible traumatic brain injury, we should never use ketamine because there's a potential that it could increase ICP. This data for this is actually quite weak, with some studies in the 1970s that said there's a possibility it might. And over the years, that was just generally accepted as dogma that you should never use this because it is something that will happen. And so the last 30 years, there's been many studies and meta-analyses of these studies that show no, it does not increase ICP, and rather it actually decreases ICP, and thus is one of the best agents that we can use in the emergency department if we have a patient post-trauma that might have a TBI that we need to intubate. Despite this, there's still a lot of clinicians out there that have this longstanding belief that no, ketamine should never go with increased ICP. So I highlight this just to demonstrate that it's often difficult to turn common clinical beliefs, even when the evidence is quite significant, showing the opposite. So it's not uncommon with ketamine and hypertension as well. As far as hypertension goes, so transient hypertension is something we see very, very regularly in the emergency department, either from pain that the patient is experiencing, anxiety of being in the emergency department or interacting with the healthcare system, and even more commonly, actually, not in the emergency department per se, but simple exercise can increase your blood pressure significantly as well. And so one of the earlier studies on this back in, I believe, the 70s or 80s showed that 9 minutes of exercise in healthy volunteers causes an average systolic blood pressure increase of about 57 millimeters of mercury. A further example of this was provided in a slide to me by Dr. Swainson. She had this slide that shows that the 50th percentile of blood pressure during exercise in healthy individuals is 160 to 180 systolic, meaning that even 50% more of those, you can see in the graphs there, go quite far above this, causing some pretty big numbers as far as hypertension is concerned. And yet none of these patients ever have antihypertensives administered or have significant deleterious effects due to these occasional episodes of hypertension induced by exercise. The emergency medicine literature strongly states that we should not be intervening on asymptomatic hypertension hypertension. Rather, this is something that if they have a family doctor, they should follow up with them, have it rechecked a few times. And if it seems like it's a consistent issue over the course of weeks to months, then it's likely they might need to start an antihypertensive agent. But in the emergency department, we don't adjust their home medications, we don't start them on new medications, and we don't treat in the emergency department asymptomatic hypertension, which is what this would be. So there's been a lot of studies that report ketamine can induce hypertension and treatment-resistant depression. The only challenge is that many of these studies kind of have significant variability from study to study in what they're seeing. So in our paper that we published, one of the studies talks about an increase of about 30 millimeters of mercury. A second one has a more significant number where 44% of patients had a blood pressure over 165 over 100, some of which were treated with antihypertensive agents. And the third study showing that 30% of patients had either blood pressure over 180 over 110 or a heart rate of greater than 110, but they didn't really delineate between these two. These effects last 2 to 4 hours and resolve on their own without the administration of antihypertensive agents, just as the ketamine wears off from the sympathetic side of things, and then it kind of returns to normal. Now, as far as the hypertensive emergency goes, this is definitely something that we need to treat in the emergency department. So we worry about this if we see somebody that comes in with symptoms that are suggestive of what we call target organ damage or end organ damage. So encephalopathy, stroke, an MI, the pulmonary edema or an aortic dissection. If these are happening and the patient has a blood pressure higher than 180 over 110, we would consider that a hypertensive emergency. And in that case, we have very specific guidelines on how much lower we have to get the blood pressure in the first hour, and then how much lower in the next 24 hours, and what medications to use and how to monitor those. It's a very difficult situation to manage, because if you overshoot it or go too low and say make them normotensive, this might be actually too low for the patient's baseline, and you could cause even more significant deleterious effects like a worsening stroke or worsening myocardial ischemia due to poor perfusion due to the hypotension. So as I was saying, the hypertensive emergency, that's just something that there's definitely guidelines to intervene on. A lot of people wonder, well, is this something that we see all the time in emerge, or is it quite rare? So just to kind of give you an idea, we have a group of about 80 emerge docs that work at our emergency department in Edmonton. Edmonton's a city of about 1 million people. Our emerge is one of the 2 tertiary trauma centers in the city, and we have about 70 emerge beds there with around 90,000 annual visits. The docs in this group range from anywhere from 1 year into practice to 35 plus years in practice. And it seems like from the poll, on average, they might see 1 to 2 cases of hypertensive emergency every 5 years, whereas in 1 week, we see about 20 patients with asymptomatic hypertension, that's blood pressures over 160 over 100, that we don't treat, and we don't start any new medications for or change any medications for. We get them to follow up with their family doctors. Now, as far as ketamine-induced hypertensive emergency goes, there have never been any case reports of ketamine, when being used for treatment-resistant depression, ever causing a hypertensive emergency. Some could argue that this is because of the very cautious guidelines that are currently in place, but I think it's much more likely that this is due to the low dosing and slow dosing that ketamine is used for treatment-resistant depression. So most of the administration for this is usually 0.4 to 0.5 milligrams per kilogram infused over 40 minutes. You can compare this to what we use in emergency medicine. So it depends on what we're using it for. If it's for analgesia, we might use 0.25 to 0.5 milligrams per kilogram in a single IV push dose. Whereas if we're needing to intubate somebody, so we need sedation for that, or if there's an agitated delirium kind of situation, we'll use 1 to 2 milligrams per kilogram in a single IV push. If it needs to go intramuscular, at that time we use 4 to 5 milligrams per kilogram intramuscularly. There is one case report that I could find of ketamine causing a hypertensive emergency in the emergency department. It was a patient that needed procedural sedation. She was a 58-year-old female, type 2 diabetic with previous CABG, hypertension, and had already had her AV and PV valves replaced, and she needed sedation for a drainage of a likely septic knee. They initially started an hour-long infusion of ketamine, which was ineffective at getting her sedate enough. So then they used another zero 0.5 milligram per kilogram single IV bolus, and that caused some pulmonary edema, SBP of 230 and a heart rate over 180. There also were a few case reports of ketamine causing perioperative hypertensive emergency, but this was in pediatric patients getting cardiac catheterization, and the perioperative environment is quite different as it's using to maintain a very deep level of sedation. So right now, the current guidelines that we use in Canada are the CANMAC guidelines. When they were written and when they were updated again in 2020, they're a very cautious approach to using ketamine, which when it was a newer medication being used for this indication, it's wise to take a cautious approach. You don't want to jump into a new medication and then sewer it by causing a lot of harmful side effects. The current guidelines state that patients with a baseline blood pressure greater than 140/90 should not proceed with treatment. So they are automatically excluded from receiving ketamine for TRD. During the infusion, if the blood pressure ever reaches 160/100, the treatment should be paused and consider using antihypertensive agents. And if it comes back below this level, you can consider resuming the infusion. So really, what's the harm in treating asymptomatic hypertension? Like if you had a patient getting ketamine infusion for TRD and they had a blood pressure of 160/100, the complications from antihypertensive agents is obviously hypotension, which in the emergency room is much more significant and much more scary of a finding than hypertension. So any kind of hypotension can cause syncope or more seriously a stroke, MI, mesenteric ischemia, all pretty significant clinical situations that you don't want to cause by pushing a hypertensive agent to treat an asymptomatic hypertension, which wasn't going to cause any issues in the first place, and now you're inducing a worse symptom as the medications likely last longer than the ketamine themselves. The other issue of where this is important to discuss is that there's a blanket exclusion criteria for a baseline blood pressure of 140/90. Unfortunately, in the population, it's becoming much more common to have patients with mild hypertension like this. In addition, there's also significant comorbidity associations between depression and hypertension, and it goes both ways, where those with cardiovascular disease are more likely to have depression, and those with depression are more likely to have cardiovascular disease. The international recommendations also state that individuals should be excluded from ketamine treatment with a blanket exclusion if they have uncontrolled hypertension, central aneurysmal disease, significant valvular disease, recent MI, or NIHA, like New York Heart Association Class 3 heart failure. So all these exclude patients from ketamine treatment. It's surprising when you contrast this to the exclusion criteria for ECT, as they're the only firm exclusion criteria is active brain bleed, and getting ECT often requires a general anesthetic, which is much more cardiovascularly compromising than this single small ketamine infusion dose. So rather than a blanket exclusion of those with a blood pressure of 140/90, just flat out not being allowed to get ketamine for TRD, it might be wise to take the ECT approach, where these patients maybe one by one kind of assess them to see whether or not they fit more inclusion criteria, or if there's just a softer contraindication for them. Just lastly, chatting about kind of what is currently recommended. So the monitoring should be at 4 time points at baseline, at 20 minutes during the infusion, 40 minutes so at the end of the infusion, and then another hour post-infusion. They recommend getting a blood pressure, heart rate, respirate, oximetry, and looking for dissociative symptoms. The challenge here is that this requires a lot of work and equipment to do all this monitoring, and for somebody receiving a ketamine infusion, it might be a bit distressing during the infusion if it causes any kind of abnormal sensations or peripheral disturbances. So in summary, really what we understand in or are taught in med school and even in emerge residency is why monitor or analyze what you're not going to treat. So instead of constantly checking the blood pressure, it would make more sense to look for the signs and symptoms of hypertensive emergency, which are the crushing chest pain, the significantly decreased level of consciousness, or severe abdominal pain, shortness of breath, syncope. These are things that would definitely prompt you to pause the infusion, check the blood pressure in this rare instance, and if it's 180 over 110, you should consider, is this a hypertensive emergency I'm seeing right here? If it is, they immediately need transfer to an emergency department, as this is an acute condition that can't be managed in any kind of outpatient situation. But barring these kind of symptoms, regularly checking the blood pressure and finding that, oh, this patient has asymptomatic hypertension, that doesn't need to be acted on or managed with antihypertensive agents, it doesn't really benefit the patient in any way to constantly be checking this blood pressure just to find out that they have a higher blood pressure. If you do administer ketamine for TRD and end up with a blood pressure over 180 over 110, and they have these signs and symptoms, and it ends up being a hypertensive emergency, you will be publishing the first case report of this have ever happening. So that's about it for the presentation I had. I'm open to any questions, and I just want to thank my collaborators there, Dr. Jen Swainson, Dr. Atul Khullar, Dr. Roger McIntyre, and Ryan Yip. Thanks, guys.
That's fantastic. Thank you very much indeed, Kevin. Really a tour de force. We've got lots of time for questions, and I think actually what we'll do is we'll carry on recording, if that's okay, so that if you're okay with that.
Yeah.
If anybody's really rude, then we can edit it afterwards. Yeah, so thank you for that. And I mean, it's just so good to have a sort of coherent exposition, if you like, of what the relative risks are. Would you write the CANMAT guidelines in a different way now?
I don't know if they want Emerge's input on them. This is definitely in their own realm, but we'd welcome any if they wanted to hear from us about it. And as far as managing hypertension goes, we'd definitely be eager to chat about it and kind of talk about risk mitigation. And the other side of risk mitigation is missing out on treating patients that could definitely benefit from ketamine infusions.
Right. Yeah, I think that's very well expressed. So, I mean, the take-home message that I'm taking away from this is that, there's really rather little point in measuring the blood pressure.
Pretty much. I think one of the best examples I can give is when we have patients that come to the emergency department and they're like, their presenting complaint is that they were at the pharmacy and they tried out one of those blood pressure cuff machines, and the pharmacist saw a big number and said, you better go to Emerge and get that checked out. And we check their blood pressure, and either it's still high and we nod our head and say, okay, or it's returned to normal when we nod our heads and say, okay, and say, just go home, get some rest, follow up with your family doctor if it's still high, or if you have these signs and symptoms that you're having a hypertensive emergency, by all means, definitely come back. But the number is just a long-term indicator of over the years that you're having your hypertension treated, how well it's being managed, not acutely what needs to be intervened on.
Great, thanks. Let's go to the questions in the chat. Good question from Tiago here. Don't you think that the altered mental status that ketamine produces could change the signs and symptoms of emergency hypertension?
I see where you're coming from there. That's why so when we talk about hypertensive emergency and the encephalopathy that comes with it, we tried to be a bit more clear that it's usually accompanied by a decreased LOC. So measuring the patient's GCS, are they like non-verbal, eyes closed, not responding to pain, like just kind of flat there on the bed? Or is it altered, where they're having an altered sensory perception and things are being perceived differently? If you're profoundly hypoxic or having an acute MI, it's unlikely that you're going to ignore the signs and symptoms that would be accompanying these like fairly life-threatening situations. The other side of things that could be argued is, well, you're infusing ketamine and you use that as an analgesia. So would that mask the concern about a chest pain or abdominal pain? And I think with kind of highlighting the amount of ketamine that is required, that we use like even 0.5 milligrams per kilogram in a single push as an analgesic dose, that infusing 0.5 milligrams over 40 minutes is unlikely to provide the level of anesthesia to completely block such a profound life-threatening pain response.
I think that's a key thing, isn't it? I mean, what I really like about that response is that I feel like I'm in a courthouse and you're my expert witness and you've just got me off the hook. So, I mean, but I think that's a very, very good point, isn't it? I mean, Tiago, do you want to come, you're welcome to come back on that if you want. So just put something in the chat if you'd like to ask about that. I mean, I think that, but there's a general further point, isn't there? That of course, with ketamine, you do get a profound change in level of consciousness, particularly, obviously, if one's using a psychedelic dose.
If I may,
yeah,
I have something to add. Yeah, I should have. I know probably the heart attack or something like that would be so great that small doses of ketamine would not be able to mask. I agree with that. But just as I just write here in the chat, as anesthesiologists, we learn to act before things happen. And that's why I think we should keep monitoring patients till they don't have the emergency. We should stop the infusion before we get above 220 systolic blood pressure, so we don't produce this kind of organ lesion in a patient. That's the point.
Yeah, I hear that. The concern is that if you keep going with the infusion and don't monitor the pressure, you might end up continually climbing into blood pressures over 220, which I have seen in emergency department and not treated. As the one case of hypertension emergency that comes to mind is somebody that came in with a blood pressure of 210 over 180, and we gave him a small dose of antihypertensive because his GCS was 6 and we thought he was having a hypertensive encephalopathy. He came back around and his GCS improved a bit to about a 10 to 11. And then after that, after admission to the ward, they continued to try and titrate up his antihypertensives, and he ended up having a hypotensive stroke because his blood pressure was too low, and he's used to sitting at 160, 170 systolic blood pressure every day. And so by acting too strongly on a hypertensive event, you can cause significant effects. And so at least from the emergency medicine side, we really, despite the number, don't treat hypertension unless it's a hypertensive emergency. And so I understand not wanting to get to a 220 number, but again, if the 220 is not accompanied by the signs and symptoms of hypertensive emergency, we wouldn't treat. Just as I think
there's a difference here. I've worked in the emergency department for a decade as well, and the difference that I see is that in one side, in emergency medicine, we are not causing anything to rise the blood pressure, and we are not the cause of that hypertension. And in anesthesia or in ketamine, we are the cause of that. I'm doing that for him, Yeah. That's what I think it changed a little bit for me as my different points of view, that I don't want to cause an MI or a stroke. So I check the blood pressure every 10, 15 minutes on my patients because I'm doing something that I know that can, and I have no defense after that. Okay, he walked in my room walking, and now he's not walking. When we are in an emergency department, they get to us not walking at all.
I get you.
I'm not the one who puts the hypertension in someone coming in the ER, but here I am the one,
I totally get that. You don't want to be inducing harm in a patient for a treatment because you're refusing to monitor or not acting early enough to prevent you causing a bad sequelae. And so I think, and I totally get what you're coming from, because in Emerge, they come to us with a hypertension and we decide whether or not to fix it. We didn't give them the hypertension. But I think in my mind, the reassuring part to me is the lack of this ever happening and the tiny dosing that's being used here, that it's so minor compared to what actually causes these. And even with those charts with the blood pressure, that 90th percentile of people exercise and get blood pressures of 220, that they induce that themselves, but we don't do anything to treat it. We just, when they stop exercising, it goes back down again. So it's quite transient, and it gets better. I hear what you're saying, though. If there is some kind of trigger or some way to know that if they're just continually escalating throughout the administration, the infusion, that they're climbing for 40 minutes straight, then yeah, I could understand your concern there.
I totally agree with you. The only thing that I think is that we're in an open clinic. Usually, we're not in an ideal world. So people usually they can use cocaine and come to do ketamine to see if it gets better or higher. I don't know. And only the cocaine itself may cause something. And I don't have any means to check it before. So.
Yeah. I hear you. Yeah.
So this is an interesting discussion, and really it hinges on managing risks, doesn't it? And that always depends a bit on your degree of risk aversion. And my observation is from doing ECT lists is that different anaesthetists have very, very different thresholds and worries about this particular issue. So, for example, I mean, although I have to say, in our practice, I can't remember an anaesthetist giving somebody who's having ECT an acute anti-hypertensive, even though the hypertension, as you say, Kevin, sometimes goes really very high. So anyway, people differ on that. Let's get through some other questions and comments. So Gina asks, how long must the blood pressure stay in the 180 over 110 range to consider it an issue?
So it's, again, comes back to the symptomatology. So it's not as much sitting at 180 for 2 hours versus 10 hours is going to make a difference. It's more when they hit that pressure, they'll be in a hypertensive emergency. One of the papers we linked or we cited and talked about in the paper talked about untreated hypertension for 6 months or longer. And so this is people with blood pressures over 160 that just never had any treatment and left it over 160 for at least 6 months. And there was no difference in that untreated management of outcomes versus those that had urgent intervention and like acutely bringing the blood pressure down and keeping them really adherent to it. No difference in admissions or cardiovascular outcomes. So when we're looking at ketamine's effects lasting 2 to 4 hours from a cardiovascular standpoint, whether it's 4 hours or 2 hours, it's probably not going to make much of a difference. And even if we're looking at 1 to 2 days, it's still kind of outside that realm. When we're looking at hypertension causing risk factors as far as heart disease and everything, we're looking in the range of months. So less as much of an issue for the treatment.
Okay. I think it's helpful to just go through these questions, although I'm going to come back to Tiago's next question, which is actually a good question as well. But Ibrahim asks, is it safe to use oral clonidine for the patient whose blood pressure goes up?
That's a good question. There's been studies, clonidine I'm not as sure about. There's been studies looking at, I know that benzodiazepines blunt the cardiovascular response of ketamine. However, it has the side effect of more profound effects on level of consciousness. And so it's even more sedating and can cause the effects of ketamine to last longer. So I don't know if you'd want that effect if it's like an outpatient kind of clinic. Clonidine I'm not sure about because of its receptor binding profile. If it would be a good alternate, I'd have to look at the data for that.
Can I jump in there for a second?
Sure.
Yep.
Kevin, that was excellent. But on this topic has come up a lot about the clonidine, but wouldn't you also agree if someone started off with a normal blood pressure and say in the middle of an infusion, they hit 160 and somebody wanted to give them oral clonidine, that by the time the infusion ended, they would be coming down on their own anyway. And then 1 hour, once you hit the peak of the clonidine's action, they're now hypotensive an hour after the infusion ended. So unless they were giving it ahead of time by an hour because they know they tend to get higher, I don't see that as a viable strategy. Does anybody have a different experience with that?
Okay, well, perhaps, does anybody want to comment on that specific issue just now? Put your hand up if you do. Otherwise, we'll go to Joanna, who's got her hand up.
And that was great, Kevin. Thank you.
Yeah,
Thanks.
Joanna.
First of all, thank you for doing this research, because we really need to really start looking at what we're excluding folks for. Because I come at this from an anesthesia perspective, I'm far more comfortable managing folks with chronic hypertension and other comorbidities that maybe the straight psych facilities aren't as comfortable with. As far as clonidine goes, giving it in the midst of the infusion for me is a no, simply because I don't want them trying to manage their airway or trying to interact with them in the middle of that. And most of my folks are listening to wave paths, have light blocking masks on, and trying to pull them out of that to manage a sip of water just to me seems rife with peril. I like 0.1 milligram for my chronic hypertensive folks that have a ton of white coat syndrome, that walk in the office with underlying anxiety that's already climbing. My chronic dysthemic depression folks, I don't seem to have as much of this with, but I will say bipolar type 2 and anybody with significant underlying anxiety or a comorbid ADHD diagnosis, I can see a lot of sympathetic activation in those folks. I like a little bit of clonidine for them for sleep, trying to get them off the trazodone, trying to get them off the benzos. And I really try to avoid benzos when I'm doing a ketamine infusion. I think you're looking at a lot of competition for receptors in that situation. And I see a decrease in efficacy if I have to reach for it. As far as the infusion goes, ECT, because I've done anesthesia for that, is so limited in its onset and then drop afterwards. Treating any hypertensive crisis was a very rare occurrence for me. That said, in the office, if I find somebody climbing who has told me that they chronically have, when their anxiety climbs, have intense headaches, one of the things that I'll check in the middle of the crisis is I'll just lift an ear pad and ask them to stick their tongue out. And I'm looking to see if I'm getting any deviation, merely to chart it. And I'm in the States, and so my charting is very legally focused. But again, thanks again for looking at this, because it would be lovely to be able to drop some of this implied need for a lot of measurement that doesn't really do us any good.
Thank you, Joanna. Rather than reply to that, Kevin, can I go to Jennifer now and ask for her input?
Thanks. Yeah, I just wanted to comment because I was one of Kevin's co-authors on this, and I'm a psychiatrist involved with our local ketamine programs, and I, worked with the CanMat group on our ketamine guidelines for Canada. So this has really been excellent to look at this and really look at what the best practices are in emergency medicine and see the discrepancy to sort of what we've been doing with patients in psychiatry. And there was a question in the chat about, how are we convincing people not to check blood pressure? And the short answer is we're not yet. We just published this, and that's in the plans for our local protocols, is to hopefully do some revisions. And my thought is keeping it sort of more in line with sort of what we're doing for ECT. So, not necessarily having hard numbers of cutoffs of, don't treat patients if blood pressure is above whatever at baseline, but, obviously patients with hypertension, trying to get them, get it controlled, beforehand, but really taking it sort of on a case-by-case basis, right? and getting medical consultation, you know, with our, when we have patients with medical comorbidities that need ECT, you know, we'll get an anesthesia consult, we'll consult internal medicine, get suggestions about anything that needs to be optimized and assess level of risk. So that's what I would sort of see. If you have a healthy person getting ketamine with no comorbidities, it's less of a concern. But if you've got somebody with lots of cardiac stuff and lots of potential risks, then I think you just sort of take it on a case-by-case basis. So, you know, it's a bit more of a gray area, but it's much more inclusive. And I think it will allow for more people to access treatment as well. So that's sort of, yeah, my comment on how we're going to implement.
Okay, well, that always all sounds like good clinical wisdom. Thank you, Jennifer. Let's just go through some more comments, unless you wanted to respond to that at all, Kevin.
No, that
okay.
Sounds good.
So have you encountered catecholamine depletion with subsequent hypotension?
So in emerge, this is a pretty big concern. So the situation that this is kind of describing is after somebody has had a prolonged catecholamine surge. So if you've been septic for a few days and your blood pressure and heart rate have been elevated for quite some time, there's the idea that you've become catecholamine deplete. So your body's stores of epinephrine and norepinephrine have kind of been exhausted, and that ketamine, when using it as a sedation agent, the reason we like it so much as opposed to something like propofol, which can cause significant hypotension, ketamine is usually blood pressure neutral. So it really doesn't cause this hypertension, except in the case where somebody might be catecholamine deplete, as we rely on ketamine's effect on increasing catecholamine release to balance out the normal hypotension that comes with a GCS of 3 after we sedate them. So in those specific cases, if somebody has been or maybe using cocaine for 3 days in a row and has had a prolonged catecholamine elevation, there is the chance that they could be catecholamine deplete and then become hypotensive when you give a significant dose of ketamine. But in my understanding, it's only when we're using ketamine to the point of true sedation, so the 1 milligram per kilogram kind of IV dosing, that's when we worry about the ketamine depletion effect.
Okay, thank you. Jane Olson's asking about the are the BP effects with ketamine similar with oral ketamine to IV, and are there any other different considerations if you're using oral ketamine?
I'm not totally sure. I think the effects on general catecholamine release would be the same. I know the oral bioavailability is quite a bit lower compared to the IV dosing. So I'd imagine that unless you're matching your dose to make up for the lack of bioavailability, regardless, it'll probably still have the same effects on blood pressure.
Yeah,
Jen might have a bit more input there. Yeah.
Yeah, I can speak to that a little bit. There's, I have seen a paper published on looking at oral ketamine and hypertension, and it looks like blood pressure does go up, but less so than we see with IV, and it's actually fairly comparable to blood pressure increases with stimulants. So, you know, I prescribe a lot of sublingual ketamine, and I, you know, personally am less concerned than I would be with IV. I think with IV, just with the kinetics and stuff, you would get more of an acute higher increase. So if you're going to run into trouble with someone with a potential hypertensive emergency, it's probably going to be with IV rather than an oral.
Okay. We're told that ketamine may increase intraocular pressure and may therefore be contraindicated in patients with glaucoma. So we can come back to that as an issue if you like. It reminds me a bit of the your very first slide about how you change perceptions. But the question is blood pressure the intermediary mechanism linking ketamine with increased intraocular pressure? And if so, what's your view of the risks of acute hypertension in patients with TRD and glaucoma?
That is I honestly know about ketamine's effects on IOP, but I, to be honest, haven't researched it. And my lack of research may mean that my understanding of its effects on IOP may be the same as my previous understanding or what we were taught on its effects on ICP. I don't know if the same meta-analyses have been done regarding IOP, because the ICP part was very hotly contended because it is such a good agent for sedation that we really wanted to show that it's really safe in this patient population. The elevated IOP crowd is, at least in Canada, a far bit smaller, and the crossover of patients with increased IOP and requiring ketamine is, again, quite a bit smaller. So I'm not sure the same studies have been done. So I can't comment clearly on IOP there, sorry.
So I'll speak to that, but if I say anything wrong, anybody can chip in and just tell me that I'm talking rubbish. But in fact, this came up on the Big Ten ketamine list just very recently, and has come up before, and so I looked it up yesterday. And there's some, it sort of was talked about in the 1970s, but there is in fact a single meta-analysis showing that in fact there isn't any raised intraocular pressure with ketamine. So as I say, somebody's welcome to shoot me down, but I think that like the ICP thing has got into the canon as being something that happens, when in fact the evidence for it is really not strong. Joanna has got something to say on it.
I will say, as somebody who's done a ton of pediatric anesthesia, the primary complaint I have from ophthalmologists about using ketamine in that population is the fact that they don't like the nystagmus that gets induced. They don't like having to chase an eyeball around a head. So I'm glad that we're making moves in that direction, because it is really a lovely drug for anesthesia in that population to stay out of opioids.
So they don't complain about the intraocular pressure.
No, they complain because the eyeball's going back and forth and they can't catch up to get it.
Okay, great. So
I may ask a question myself in the meantime. Actually, maybe a couple, don't mind having. I'm a psychiatrist by background, so please everybody be patient. Like, for example, I saw the value you showed, and I completely understand that like the clinical picture and the symptoms that the patient presents are way more relevant than just like a cutoff. But sometimes it may be the systolic is higher compared to diastolic or vice versa. So my question is like, is this one of those two values that would be more relevant for you in the moment we do an infusion? They will like advise you to eventually pause it. And my other question is that I do understand the cutoff and the reasoning behind it, but maybe would that be like a change, like a delta in between the blood pressure they have a baseline and the one they reach during the course of the infusion that warrant, for example, to pause or to stop the infusion?
Yeah, so two parts there. Trying to attribute some significance between systolic increases and diastolic increases. And then the second part being, if your baseline BP is elevated, is there a delta that you're more concerned about rather than the true number of the final? So to the first part, my understanding is limited, as I'm not an internist or an anesthesiologist as far as systolic and diastolic, but my understanding is that the diastolic changes are usually more chronic in nature, and smaller increases of diastolic can cause larger problems because the heart is resting at a higher, your general resting vascular tone is higher, causing more issues for forward flow for the heart, whereas the systolic increases, you can have larger changes, and those changes usually occur more acutely in response to things like exercise or anxiety. So you see much larger numbers and changes in the systolic side of things rather than diastolic. But the diastolic, when it's changing, it's something to kind of pay a bit more attention to, even though it's much less talked about. If there's any anesthesiologists that want to chip in on that, I'm welcome to taking that too. As far as the second point, is there a delta you're more concerned about? Not necessarily. I think it's challenging to make any firm conclusions because it's all these cases that we have case reports about hypertensive emergencies. It's not necessarily that they hit a certain trigger point and then had this cascade of problems. It's just it overwhelmed the body's ability to compensate in whatever regards, and that delta value or that final number might be different for every person. So it's not that I can say that there's a clear, oh, if you're already at 160, if you go to 200, things will be bad. It's more just that for some people, hitting 180 might be the trigger point for this cascade of problems causing a hypertensive emergency. But I don't know if I don't know if there's a way to kind of give a firm number for that, either a delta versus a final number.
Okay, thanks. I'm going to ask Tiago if he's still there, if he wants to come back on the question of ASA classification.
I'm here.
That's a bit of a sort of one way of trying to think about this.
Yeah, I was wondering, in anesthesiology, we have the ambulatory anesthesia, ambulatory surgery rules. We already have that. It's already written. And why we don't simply apply those rules for ketamine? That's what I do here. Why won't we just do it? So we need to classify the patient physical status 1 or 2. If it's 3, we cannot do it. If it's 1 or 2, we can do it. If you're in doubt for which one, always don't do it and check with the clinician, and we can answer all our questions on that way. I don't know if I'm being oversimplistic when thinking about that, but as our colleague here on the chat, aneurysmal malformation, have you ever done it? Would I do a case for something like broken bone? If a patient had aneurysmal malformation, I just need to think, there's any surgical thing to do with this patient? No, there isn't. So let's do it. No, there is, you need to address first the disease. So glaucoma, intraocular hypertension. If it's not addressed by ophthalmologist, don't do it. If it's already addressed, nothing to do with that, let's do it. Let's do ketamine. So it's oversimplistic. I don't know.
Jennifer, do you want to respond to that?
Oh, yeah, I just wanted to comment that I think, I think it's important for us to remember too, that when we're considering who to treat for ketamine and what role some of these comorbidities may play, not every patient in every situation is the same, right? There's a lot of different settings, a lot of different types of ketamine clinics, across the world. And, it's a little bit different for somebody with maybe a more kind of mild to moderate depression that wants to go in and pay privately for a ketamine infusion in the US versus someone that is a hospitalized inpatient with severe suicidality that may need ketamine, right? So I think we really have to, consider the severity of the illness, the psychiatric illness, in weighing this as well. That's just the point I wanted to make.
Thank you. That just reminds me of the rather tense discussions I've sometimes had with anaesthetists in trying to persuade them to anaesthetize patients for ECT. And of course, the psychiatric condition can itself increase the blood pressure. Kevin, do you want to say anything about that?
No, I hear you there.
Okay.
I get Tiago's. I just wanted to comment on Tiago's point there with ASA. I think it's a great idea because it's a nice broad classification system. I think it'd be a bit harder. You probably still need anesthesia's input on some way to get a good ASA level, or have some workshop that kind of trains any psychiatrist using ketamine to be able to look at a patient's history and eyeball them an ASA number. But then you can kind of quickly rule in, rule out on a broader category instead of such hard absolutes.
Tiago, could you just give for the audience a sort of broad idea of what somebody who's ASA 3 might look like?
Okay, the classification risk, it's divided in one. I put it here in chat, everything. Let me see, I put it again. Let me do this so anyone can see how it goes. Basically, if a patient doesn't have any disease, he's one healthy, normal patient, doesn't smoke, doesn't use alcohol, doesn't have hypertension. Number 2, they have some disease, but it's worked out. So they have mild hypertension that or is treated, no BMI, exaggerated BMI like 50 to 40, it's okay. It's number 2. And the 3, they have a systemic disease that may interfere with the result of the surgery or the anesthesia, like uncontrolled diabetes. So that will foresee the death in 30 days. It's a greater risk of death in 30 days of this patient with something not related to the surgery in that moment, like diabetes. And we have number 4, that it's a life, that disease is a constant life threat, like an AMI, a recent EMI. That's, I think, the more common thing to see. Number 5, it's a patient who is not expected to live unless it's treated. So like an aneurysm, ruptured aneurysm, something like that. And number 6, it's a brain dead patient. So if we use this classification, we can see that a lot of our doubts will be addressed there. And there is the gray area between those lines. And as Kevin said, it's not something difficult to teach for a clinician, for a psychiatrist. I bet one day, I don't know, 4-6 hours, you just see some gray area cases and you're done to make this classification by yourself. You may not be correct all the times, but you can always go to the no more frequently than the yes, and we'll be fine.
Great, thanks very much for that. That's really helpful.
Thank you.
And just to follow up on the intraocular pressure question, Dave Dansky has put a note here: intraocular pressure stable up to 3 milligrams per kilogram of ketamine, mild elevation at 6 milligrams per kilogram in a pediatric study. So that's really helpful, thanks.
Can I just jump in for 1 second?
Yep.
The ASA guideline, I think one of the pieces as we evolve in this flavor of treatment is I would love to see the ASA have an additional guideline put on it for mental health. And the reason for that is for somebody who is actively suicidal with a plan, who's had that plan interrupted and been brought into care. Many times the ASA is so physiologically focused that we miss that part. And I have made the argument on more than one occasion, taking somebody back to surgery who maybe, I've done it for ECT with somebody with active suicidal ideation. I've also said, if we have somebody who desperately wants surgery that may or may not have a long-term effect on their prognosis, but for them, this has become the hill that they're going to die on, so to speak. I think it's sort of invalidating for anesthesia to say, I'm not taking you back. I'm declining to give you an anesthetic because the numbers say that it's not going to physically help you. But that I'm willing to take you back and give you that shot for that human, even if it doesn't work out. There has to be value to somebody's autonomy of making choices. And I think we've really just subtracted off the mental in that piece. And I think it makes us as anesthesia who like our hard numbers very comfortable, but it's a disservice to our patients. Somebody who has active suicidal ideation, who may have a AV malformation or may have something that increases their risk, a distant history of seizure disorder, whatever it is, we have to start grading that mental health piece to yes. Oh, Tiago, psychiatric anesthesia. I'm right there. I'll jump on anytime for that. I really just think we need to be far more mindful. And I think anesthesia really needs to sort of move the ball. I would love to see practices where, depending on the patient's ASA, kind of depends who the provider is in the room. And if you are an ASA 3 to 4, you should have anesthesia at the bedside doing your ketamine infusion, despite the risk, because that's the safest thing for you. And the comfort of the staff. I don't want a psychiatrist taking a patient for a ketamine infusion who may not be comfortable looking after that person because they're worried about the risks that they don't necessarily understand. That's my bread and butter.
I think what you're saying is about the gray areas, the gray cases that we don't have a hard number to rely on. So you need someone, I think thousands and thousands of patients, and I know how ketamine can help. But if you were talking to myself like 8 years ago, I would say, you have, I don't know, try something else. Not ketamine. I will not risk myself on ketamine, risk the patient on ketamine, try something. But now, after tons of patients, I would say, let's do it. No problem. I deal with the complications later. I don't know, bring me the nitroglycerin. I don't know. I will make this happen. I will make this happen, as I do in a ERs or emergency situation for anesthesia. Oh, the guy has a knife in his chest, but oh, I believe he's uncontrolled diabetic. So would I not anesthetize? I say, no, let's do it. And I deal with the problems during the case.
And I think when we look at these folks who have intensive suicidal ideation, well, any suicidal ideation, I think, to me, when I classify them on an ASA, it puts an E next to their ASA classification. This is emergent. We have somebody who, if they walk out the door without treatment, have a hugely increased risk of doing significant harm to themselves.
So we need a subspecialty psychiatric anesthesia.
Exactly.
Sounds like Tiago is going to be the president of the First Society.
I'm on it. Let's do it.
I think we're going to stop there, actually. There's one more.